Good morning, everybody. We'll get started. I welcome all of you in the room and online watching the Grand Rounds today, where we have a very exciting topic and a speaker. But before I introduce the speaker today, I want to go over some of the housekeeping stuff. This is being live casted on LiveStream, Facebook, and YouTube. And during question time, please use the microphones, individuals in the room. Also, after the Grand Rounds at 9:45, there is a one-on-one interview that I will be doing of our Grand Round speaker, in which all of you and people watching online can send in questions that he will answer through Poll Everywhere. The instructions will be on the screen as you're watching it. There are two conferences that are coming up for you to take note of. There's the annual Adult Congenital Symposium coming up October 12th. It's a really good conference, both for physicians, and then there's some exposure to patients and individuals who have battled adult congenital disease. So look out for it, and I think you can still register. There's also Pumps and Pipes, which is a fascinating conference as a collaboration between the medical, oil, and space agencies in Houston. It's on November 11th, so look out for it, and if you're interested, please register. So today's speaker is Dr. Stavros Drakos. He's currently a professor of cardiology at University of Utah. He's the co-chief of the Heart Failure and Transplant Section, director of the Mechanical Circulatory Support Program. He's also the director of CV Research and has done phenomenal work over his training and overall his professional career. He did his med school and PhD in Athens, and followed by clinical training in Athens and Utah. And then he decided that's not enough. So he did a postdoc fellowship and focused most of his research in recovery. And he had the luxury and I guess the luck of getting mentored by none other than the legend Sir Magdi Yaqub, who was a pioneer in recovery. And I'm sure Stavros would make Sir Yaqub proud with the work he's done. He's had many funding grants from NIH throughout his training and as a faculty. Currently, he's the PI for the AHA Strategically Focused Network Grants, which is one of the largest grants that I think I know of for heart failure. And he's done an exceptional work, not only in promoting the field of cardiac recovery, but also promoting the science behind it, organizing a conference called as UCARS, which focuses on cardiac recovery, and has mentored many fellows, residents, and has contributed to the field, and we're really lucky and happy to have him here. So please welcome Dr. Drakos on to give us an insight.
Good morning, everybody. Thank you for coming to this talk. I'm very, very happy to be here at your historic institution. I'm grateful to Arvind and Barry and the team for the invitation. Thank you for this warm welcome, and thank you for your good work, Arvind. Today we'll talk, as Arvind said, about recovery, heart recovery, and how we look at it. I started with this picture, which is the wrong picture to show in Houston. If you want to impress people in Houston, you shouldn't show Salt Lake City lights. You should show the mountains, right? That's what you should show when you come to Houston. And then you may even show how they look at night, in a winter night from where we work. So that's what you show in Houston, right, Arvind? You don't show the city lights here. We are very small for that, right? So reverse remodeling and heart recovery that we will talk about today. I just want to start putting it in perspective that when we round every day in the wards and in the ICU, this is not an exotic thing. This is something that happens to a lot of our patients. And in this inner ring here, you can see the things we can do, and we see on a daily basis recovery. We see recovery when we pace the ventricles together in a synchronized way, as you know. We see recovery when we control the tachycardia in a tachycardia induced. We see recovery when we abstain from alcohol. We see recovery when we treat people with angiotensin receptor blockers or ACE inhibitors or Entresto. We see recovery when we fix the aortic valve, classic aortic stenosis-induced cardiomyopathy, right? Which is something that reverses. So we see recovery on a daily basis. And the dogma which prevailed for decades that the human heart is incapable of recovering from severe injury is being canceled on a daily basis as we work in our rounds from what we see. The left ventricular assist devices is just one of the ways that you can see these. And we will talk later down the talk why these could provide an opportunity to gain further insights of how it happens, when it happens, and how you can use it to impact one of the global epidemics we have nowadays, which is what? Heart failure is breaking the bank everywhere, as you know, and especially in this country. So just to go back to Doug Mann's work, given that we are in Houston, right? We should talk about some of the legends that you guys nurture here over the decades. At Baylor, that actually was working with the Methodist for all these years. When he was at Baylor, Doug and others have shown that the load, as we know, wall stress, drives this forward progression of heart failure. So the hypothesis generated, relevant to what we're talking about, mechanical assist devices, is that by removing this load, and you are all familiar with mechanical assist devices, this is the first generation, the big ones, right? It's a simple approach. Suck the blood from the ventricle to the pump and from there to the aorta. They unload the heart. So the question is whether by doing that, you could reverse this deleterious process of remodeling, adverse cardiac remodeling, and induce cardiac remodeling. That's what we're talking about. That's what we will show. Here, you see one of our patients. Let's call this patient A, improved heart function, call this patient responder. You can appreciate in the 4-chamber view how the heart is squeezing better with the pump turned down to the minimum allowed to load the heart again a few months later. You see that, and then the basic scientist in the room will go, well, of course this is going to happen. You remove the load from the heart is going to recover. Well, no, this is not happening to everybody. Then you show them another patient who started like the one above. Let's call this patient B. And this is the majority of the patients with end-stage heart failure, that you will remove the load with the same pump for the same period of time, same etiology, same duration of heart failure before the intervention, and you're not going to see any response. So that's intriguing. You see that in front of you. And actually, the first report of what I just showed you came from where? Came from Houston. And Bud Frazier was one of the first persons that they reported this, showing the hearts when we transplanted people after LVAD getting better. So regardless of the sustainability of this, when you remove the pump and what happens years later, right there, just to understand why one heart clicked differently than the other, right there, from a biological point of view, it has tremendous translational and clinical implications. And we will talk also about the clinical implications and the practical ones about the sustainability of this phenomenon. I'm going to start with this late-breaking clinical trial, which was presented for the people not experts in heart failure. This is one of our biggest conferences internationally that Arvind and Barry and Nadia and the team here goes every year, called ISHLT. And we presented this data from this multi-center trial we did, where we used left ventricular assist devices and medications to see what would be the response. And these were the inclusion criteria: non-ischemic patients, age less than 60, low EF, big heart, but the duration was less than 5 years. So it was not patients burned out for 10, 15 years. For specific reasons, we selected this population. We knew from prior studies that this is the population more prone to respond. This is the RESTAGE trial, and this is the enrollment. Louisville, Utah, Penn, Nebraska, Monte and Cleveland Clinic. And the criteria to remove the pump that were implemented were a classic Herfield study, Herfield protocol from UK criteria. You can see there echo criteria and hemodynamics with right heart caths. And that's where we put the bar, normalize the echo and the right heart cath with the pump turned down to the minimum. These were the criteria that when the patient reached them after months of being unloaded with an LVAD and hit with medications, you would remove the pump. So I'm going to share from the baseline characteristics of this trial that we did. It was an observational study, no control group, no randomization. We're doing this now. You can see there the LVDD 73, and just to suggest that these were chronic and dilated, not hearts that they were acutely failing and they were going to spontaneously recover anyway. And of course, low EF, inotrope dependent, most of these patients. The echo core lab was at Montefiore at Albert Einstein, and you can see there the ejection fraction over time, and you can see the groups of responders and non-responders I showed you before. Higher rate of responders here given the patient selection we did based on those criteria. And here the volumes and the diameters follow the same pattern, again with responders and non-responders over time. So 36 patients out of the 40 completed the protocol. They were treated with medications, heart failure standard doses that we use in the guidelines, and with LVADs. And out of the 36 patients that they survived the peri-op period and they follow the protocol, 50% of them, in all 6 sites we had explantation, the pumps were removed, which was 50% explantation rate out of the 36 or 40-something if you go from the initial 40. And the primary endpoint was not that. The primary endpoint is what happens 1 year. When we have somebody responding on a beta blocker, we don't remove the beta blocker, right? When somebody responds to CRT, you're not going to stop the CRT. Here, we are taking the pumps out because they have the complications you all know and all this. So you are removing one of the big components that make this patient recover. So the question mark is what's going to happen later. If the heart failure is going to come back in a month later, then it's not worth it, right? So this is the primary endpoint, which was 1 year later. And you can see that 89% were freedom from heart failure recurrence 1 year later. And we'll talk more about the sustainability of this phenomenon later down the talk. One of the questions that comes up when you see that, then you go, okay, that's a selected population, right? Non-ischemics, young, not more than 5 years, chronic heart failure. So what's going to happen if you go to the whole chronic heart failure population? All comers, ischemics and non-ischemics. What would be the response rate there? Is this a phenomenon that happens in some selected population only? So a few years ago, we were invited to write this review and put our perspective, and we defined, again, what I showed in this review, the same slide I showed you with the load and the unloading, and across that, the questions that we wanted to begin answering during the next 10 years. And today, we are 7, 8 years after that, we put that together. I'm going to share with you some of the answers in all these questions across this continuum that we have. And one of the questions we ask, which is related with what I just asked after the trial, is what's the impact of heart failure etiology in all comers, ischemics and non-ischemics. So that's a study that Anna and James did. Anna is now, they both were tortured by me when they were fellows, and now they are junior faculty. Anna is directing our echo lab, and James is at the University of Florida as junior heart failure faculty. So during their term, they read thousands of echoes, as you know, on all these patients, serially following them and all this. And this is some of the work they did. And one of the questions we asked in these 154 consecutive patients over more than a year of follow-up was, we put the bar high, as you can see there. The EF had to respond to more than 40 and the volume to decrease more than 20%. And what they found, again, I'm drawing the same picture, was that in about 6 to 12 months, usually around 6 months, in an average, 14% of the patients, which breaks in 5% of ischemics, they have the scars from the MI, so the response rate there will be lower. And 20% approximately of non-ischemics, 1 in 5 and 1 in 20, with an average of 14%, will respond. That's what we found in this JACC paper. You can see it online and read more about it. And then the question is, okay, you're in Utah, you were looking on all of these people prospectively, what happens in other centers? You know, people in Utah don't smoke, don't drink as much, so maybe that's why you have good results, right? So This is a Intermax registry. As you may be familiar, Intermax is a national LVAD registry where all of the hospitals had to report what's going on with their ventricular assist devices. So Omar, who was also tortured when he was a cardiology fellow by our team, he also now is junior faculty with us running our hypertrophic program. And he has worked a lot over the years with my team, producing a lot of papers, as you will see down the talk. One of the pieces of work he did, he went to these 15,000 patients of Intermax, and we looked there, the classic thing, only 1.3% were explanted for recovery. All these centers that they were using LVADs as a DT, destination therapy, or bridge to transplant. So we go like, what's going on here? We are finding, we need to look into this more. So then he go and then, how many more people, 15,000. How many of those had follow-up echoes in Intermax? Just what they reported in Intermax. 7,000 had follow-up echoes. So let's see what they reported in Intermax, all these 7,000 patients from all over the country. And you will see there that they reported another 12% of the patients improving their EF more than 40%. And if you add the two, you're going to go, even in the centers that they didn't have prospective programs and research infrastructure to do the protocols, that they were going to push, even in those centers, you will find, if you add the two, a percentage of patients which is going to be similar to our prospective study. And then the Columbia guys, Veli Topkara, you may know Veli and Paolo, and our colleagues from there, Donna Mancini and the surgeons, reported the same thing in circular failure a few months later. They got the same Intermax data, and they found the same thing, that this is what's happening. So that's the opportunity that you get across the board. So biology, as we know, is not always like pregnancy and death. You are either pregnant or not pregnant, dead or alive. But most of the phenomena in biology is not all or none, right? It's not binary. And that's what we found in that Intermax paper, and the Columbia people found as well, that we're talking about a continuous spectrum here. So it's not a dichotomous recovery or non-recovery. And I'm going to show this with this study we're doing now, and it's under review with the INNOVA group in DC. So we got the INNOVA population from the DC area, and the Utah, which, as you know, we cover 9 states around the Intermountain West, all the way from Montana to New Mexico and from Nevada to Colorado and northern Arizona. So if you take all these patients, and with turquoise is their baseline dot, and with brown, gray, brownish, I would say yellowish, is what happened after the LVAD unloading in this consecutive 360 patients between INNOVA and Utah. You will see there, here is the LVF above 40, which we consider a good threshold to say that the patient now has changed his or her prognosis. And you can see here the LVDD less than 6. And you see how you move to this quartile there. Nobody was there before. And you can see the movement of some patients to normalizing their dimensions and improving significantly their function. So to put our hands around it, let's get the patients that they have these more than 40% EF and less than 60 LVDD, call them responders. 10% of the patients were like this. How about the rest of the patients? The ones that they didn't improve their EF to more than 40, there was another 10%, we call them partial responders in this paper, which is under review right now, which they improved their EF more than 10%. So just to give you an example, a patient who starts from 15% EF and goes to 37, or from 10% goes to 33, this person improved 300% their function. But still, for us, it's not as good because it's less than 35, it's going to get ICDs, but biologically means something. And if you focus in this patient and give medications and all this, you might complete this process of recovery later. So these partial responders is a group that we think that we should focus on more. And then, of course, we have the other patients that they improved their absolute EF number, 5 to 10%, we call them borderline responders. And of course, the majority of patients, around 60%, they didn't really improve the progression of disease. And we're trying to understand why these differential responses. As you know, heart failure is not one thing. It's a heterogeneous population with many etiologies. And this is the change in function and structure over time in these patients. And you can see from the time course there that between 3 to 9 months, maximum 12, you will see most of the response, which has clinical implications on how you make decisions about where to allocate these organs. So what we are proposing in the central illustration of this paper is that you should, when you see this response, you should begin doing the formal explantation testing after continuing, improving the unloading. The dose of the LVAD is the LVAD speed, right? So you should unload, maybe continue maximize the guideline-directed medical therapy, and then do the testing that I showed you before with the echo and the right heart cath turn down at the restage trial to consider whether this patient has recovered, and give the donor, the precious donor. We have only 4,000 donors per year, and we have almost 100,000 patients, right, waiting. So give them to people that are not going to recover. And then when you see the partial responders, go do a right heart cath, maybe they are not unloaded as much. As we see this all the time, we have the Intellect 2 study that I'm in the steering committee. You guys are participating, and thank you for your participation. 30% of the LVAD patients come back in the hospital with heart failure symptoms, and they are not unloaded as we think. So because we put the monster there called LVAD, it doesn't mean that it always does the job. Sometimes you need to play with the RPM, the dose of the LVAD, and further optimize the patients. So we think that we're unloading, but we are not always unloading. So maybe these partial responders can become responders if you focus on them, optimize heart failure medications and all this. And then the rest of the patients, the borderline and the non-responders, you can allocate the donor hearts to them. So that's a paradigm that we are proposing in this paper, which is now under review with Innova. So what is the sustainability of this phenomenon? As we said before, if you're going to take out the pumps and the heart failure comes back within a month or two, it's not worth it, right? The hassle and the surgeries and all this trouble for nothing. So in restage, these 16 patients that we explanted, now we have in 3 of them over 4 years. The paper is under review right now of this restage trial. You will be able to read it soon. But you will see there that from these 16 patients, they are retaining, with this follow-up, their results here, which is a very good result. And then 2 of them had heart failure recurrence. 1 of them was a true recurrence despite being on medications. The other patient, bipolar, stopped meds, as you know from the British trial that was just published. If you stop your heart failure meds, heart failure is going to come back. So the Berlin series is the largest and the longest. And their 5-year survival of their 47 patients in those publications that they removed the pumps was 76%. So what's the alternative? So when you have a patient, this is a practical question that the patient asks you. And we get this question every day when he or she comes to your office and says, what's now, doc? I mean, I just got this echo report with your fellow, and they are telling me that the heart recovered. So should I take the pump out? So what's the alternative? One alternative is to transplant the patient. The other alternative is to keep the patient on the pump, right? That's the other 2 alternatives you have. So if you compare with keeping the patient on the pump, this is the Intermax 5-year survival. And you will see there that this 76% compares to 46%. So it's not randomized, of course, but it's the best we have. And that's why we're now doing what? We're doing a study. I thought I had it here, but I'll show the slide later. We're doing a study now that we're trying to collect all of the explantation data from everywhere. And your program is participating in this study and see the long-term outcomes of even more patients. But if you compare the first alternative here, the results are very promising. So the second alternative is to transplant the patient. So my mentor, Jacob, who is the equivalent, the European equivalent of DeBakey and Kool-Aid, and did that with Emma, one of my partners now in the US when she used to be a fellow there, and I was at the University of Athens. And we were doing this recovery work as cardiologists being overseen by Sir Jacob. And what we did here is that we took 40 patients that we explanted after the LVAD got out, and we compared them with another propensity-matched group that was transplanted. And of course, we don't want to show that we are better than transplant. We want to show that you are non-inferior. So you don't have enough donors for everybody. So that's an alternative. And for young patients, you may have seen Pat Frazier showing this famous slide, all of the Houston patients that they transplanted young, because the 10-year survival is 60%, how they don't make it to the age they would like. So if you can postpone transplanting young patients for later and use the donor grafts for the ones that don't recover, you offer something to the field. So that's the point here, that the alternative of transplant, and that's what the patients will ask you. Should I just get my heart, or should I get it out and wait, postpone transplant for later? And we never had a patient deciding to go the way of transplant when we offer them this data. They always like, unless they are old. If somebody is old, then you might not want to do that, because if the heart failure comes back and you are 62, when it comes back and you are 67, Arvind and the team here will say, well, you're above 65, and if you're not looking good, they might not do the exception, right? So when you are old, you may not want to do that. But for young patients, so I talked to you about survival. How about recurrence of heart failure? They survive, but do they survive without heart failure? Because if heart failure is going to come back, then this survival is meaningless if you're going to be puffing and with edema. So there's Germans, and you can see here all of their patients, individual patients, up to 15 years follow-up with red, you can see the ones that they have heart failure recurrence. So the freedom from recurrence was 67%. So 76 was the survival, and the freedom was 67. Again, you need to compare these with what? You need to compare it with the alternative. And the alternatives I just showed you, what are the alternatives? How about exercise capacity? So the Newcastle group with the Healthful group, they did this study where they looked at healthy controls. They look at patients that they remove the pump with the orange here. They looked at LVAD patients. They have their LVAD waiting for transplant or DT. And they looked at patients that they were bridged to transplant with mediations or other things. And you can see here that the explanted patients, they achieve a peak oxygen consumption almost similar to the normal controls. And if you look over the years, there is significant stability up to 6 years of follow-up. Again, we need to do control studies, and that's what we're doing now. So this is what I was looking for before, where Nadia and Arvind are participating with us, collecting all of the explanted patients from all over the world. The small numbers that each institution has, in order to get another group then, transplanted patients from ICLT databases and one from Intermax, match them and see how do these patients do with a follow-up of many years versus the two alternatives, right? And of course, down the road, we will need to do a randomized study as well, but that's the first step. Can we predict this response? That's what people ask you sometimes. Can you, because if you can predict this response, maybe you can go a little bit earlier, before the heart is burned out completely, and then get more recoverability. Omar again, I showed you before now, his junior faculty, as we said, with us, looked into this. And this is the Intermax, thousands of patients that they are in the Intermax database. And you can see here things that you think make sense to predict response. Younger, non-ischemics, I showed you before the prospective study. Less time diseased heart, makes sense. Less burned out cardiomyopathy. Implanted with ICD, no, yes. So the ones that they didn't have ICD, they were 10 to. This shows how the clinicians, because they knew that this patient was relatively early, they wanted to give time on medications and other things. So that was a surrogate of the duration of disease, we think. Creatinine, the lower the better, and then less dilation. Dilated, but not super dilated, which makes sense, less burned out cardiomyopathy. And then when you put this, the one that they have more than 7, if you go to Intermax, and if you go to sites that they didn't have a bridge to recovery, BTR strategy, because it counts, right? If you don't wait and you just transplant somebody quickly, you're never going to see the response. So the response rate was about 8. If you go to the centers that they were waiting and they were looking for it, then you will have a response rate of 24. In our hands, that we look very carefully on everybody, it goes all the way to 38% if you have these predictors and you have a score of more than 7. Now, this goes from Intermax. Joseph, who is another fellow being tortured, doing all this work, has a new study that we looked on our prospective cohort, not the Intermax, which, as you know, it's from all over the country, the data, the granularity. It's not the well-controlled environment of one institution looking at very carefully all of the CRFs and everything with focus on this protocol. The predictors we found, and we had more than 300 patients, as you can see here, female gender came up. And we knew this from CRT, that the females get to respond better, they are more resilient. We also know this from life, right? And duration of disease and no prior heart surgery, which we think is a surrogate for the ischemic cardiomyopathy, also bad valvular cases, another predictor of response. And if you put them together, and if you have a score of more than 5 to 9, your response rate is almost 1 in 3, with good area under the curve. So this is Michael. Michael now is back to my home institution at the Onassis Heart Center in the University of Athens in Greece. He trained in echo with Ted Abraham in Hopkins before Ted going to UCSF, which is one of the best echo labs. You guys have a great imaging group who can appreciate a torsion, rotational mechanic study. So he learned from Ted rotational mechanics, and he came from Heart Fellowship. I knew him from when he was a medical student at the University of Athens. He came, and I told him, you should use all these strengths that you have in rotational mechanics and advanced echo. Our idea was that all of these people, when they go for LVADs, they have low EF, right? Otherwise, CMS is not going to pay. However, some of them retain the torsion. So our hypothesis was that the ones that they retain the torsion, maybe this is a marker of a healthier heart, sick but healthier, and maybe these are the ones that they will recover. All of them had low EF. And that's what we found in this study, that the ones that they retained the torsion was a strong predictor of response after the mechanical assist. And then we go deeper, and we take the tissue from these patients, as you know, to see whether we can find in the tissue something that can guide us. And so this is T-tubule study. I'm not going to go into the details, but you know, T-tubules are excitation, contraction, coupling, and you should have this junctional RYR with the T-tubules, right? The T-tubules are going to create the contraction and get the excitation to become contraction, right? So you need to have these. What we found in our patients was that they looked like sheets here. That was a novel find. That's why we make it all the way to circulation. And they were not junctional with their ionizing receptors. So when we saw that, we said, okay, let's see whether these, what is going to show these later. And indeed, the ones that they retain that, these are the ones that they recover. The minority that recovers, right? Around 15%, as we said. The ones that they had that, so the editorial, we have been all talking about this point of no return, a point beyond which the remodeling is non-reversible. Maybe that's one of the characteristics of the point of no return, along with the characteristics in the charts I showed you before and the rotational. So we begin understanding slowly now who are these patients that they are beyond the point of course, you're going to give up on those and use a donor heart for those. They're never going to come back. Who's going to do tissue biopsies to get these T-tubules to tell you who to do and what? I mean, you don't want to do that. I mean, it's a little bit, it would be better to have something in the blood, right? So Nikos, who was also tortured by us for many years, he did residency, research, PhD. Now he's doing cardiology in Tufts. We send them to see other things as well, so they don't think that we are the only people talking about these things. So this is something that he started with us, and he's going to publish. He presented it in ACC. We started from the tissue. We saw the cytokines in the tissue that we get in the LVAD patients, right? That they can predict the response. And then we went to the serum because cytokines circulate in the serum as well. Narrowed the targets from the tissue findings to see whether we can find something in the blood that you can draw and predict who is going to respond. That's the idea. So what we are finding here, and this paper is under review now, is that interferon gamma and TNF alpha, again, we are in Houston, TNF alpha, Dagman, Renaissance, all these studies here, right? It's coming back. We knew that inflammation is never going to die in heart failure, right? It's one of the drivers. It's important. It didn't work in that trial because it affected other things as well. But we know from work that was done in this city how important it is. So, and this is the area under the curve with an unbelievable 0.9, which is one of the problems I think we will have because it's too good to be true. 0.9, not even BNP has 0.9. So we are going to try to get this out, and the manuscript is under review. Again, in this continuum, type of unloading, is it going to be pulsatile, non-pulsatile, counter-pulsatile? Mohammed, who is now doing his residency at the University of Toledo, was also tortured by our team for several years doing research. So he compared the centrifugal and the axial flow type of unloading. And that's what he found, that by LVDD and by LVF, there was no difference in the way you unload the heart, which is a question going forward between these types of unloading. We're looking into this more to understand it better. Targeted adjuvant therapies. So what are the things we can give on top of the heart failure medications, right? But the first question, before we go to the other things we need to give, Sharon Han, who is a legend in heart transplant, asked me this question 3-4 Gorton conferences ago. And when a legend asks you a question, you better act. So we said, okay, we need to do this study because Sharon is asking about it and others. Is it because of the pumps, guys? Or now because you have the pumps, you give all these heart failure medications because the patient can tolerate them now when they have a hemodynamic breach. Maybe that's why they recover, right? So Anna did another study. We took 50 patients that they had LVAD and all heart failure drugs. And we did another 39 patients that they were only on reverse remodeling naive blood pressure medications for their LVAD when they have blood, like calcium channel blockers or other things. And we compared this. It was not a randomized study, but what we found was that it was both. They acted synergistically. So the group that had no meds, just the LVAD, improved their EF and their dimensions of their heart, they shrunk, right? But not as much as the ones that they had the meds. So it's both, and it makes sense. So that's what we found in this study. How about more therapies? Now I'm going to move to a smaller second part of this talk, which is why we really do this. Of course, we care about the LVAD patients and the transplants, but most of these people in this room go like, this is just a small group of heart failure patients. This is not what breaks the bank. We have all these millions and millions of patients in the country. So can you really find something from these to impact the whole heart failure field? Can you understand why the heart recovers by these studies and just impact the whole field of heart failure? And this is what the NIH was interested as well. So that's why I got the honor to chair this working group, where we got bench-to-bedside people from all over the world. We locked them for a couple of days in Bethesda, and we thought and brainstormed a couple of years ago, and you can find the executive summary in the website, and the white paper came out in 4 scientific journals. And what we found and what we thought was that you can take advantage of this core that you get, and you guys get it here as well. And you can do all these things, and then you can phenotype the patients over time. And then you know who is responder, partial responder, non-responder. And then you can take the heart transplant, and then you have a huge model. I mean, a very powerful model. And why is powerful? Because it gives you human heart tissue and blood. It gives it to you serially before and after the intervention. You can assign it to the response. And the heart failure animal models, they're not good because they cannot recapitulate the chronicity and other aspects. So you have a unique way to begin looking at something that the oncologists are so far ahead of us. In pharmacogenomics, you know, Angelina Jolie is cutting her breasts. We don't have this paradigm in cardiology to go see something in your genes and then act. We're not so far ahead. They always had the human tissue because the tumors come out. That's why they're so far ahead of us. And now we have a unique opportunity to do something similar that they are doing. So that was the white paper that came out in these 4 journals, Cardiology, Surgery, Bioengineering, and Basic Science, suggesting that I redraw the rainbow I showed you before, that we can recover the heart with all these things that we talked about. These can act like a magnifying glass that can show you because of the tissue that you get and can get you where the oncologists are already going, precision medicine, and begin understanding deeper what's going on. So this is our program. We started in, this is, you know, the whole Intermountain West. Our VA is one of the 5 VAs that they do transplant. So we have a lot of patients from Houston and from Dallas. And whenever I show this slide, my parents say, we don't show Houston and Dallas. People will think we go there to outreach. And no. They will understand. It's the VA. So we get a lot of, we don't come here for outreach, don't worry. So we get the VA patients from here. And we have patients back to the point that this is not a selected population from one state. You can see. And of course, we started now collaborating with more and more sites from all over the country more recently, so we can improve the diversity of the samples in the East Coast. Looking at the biology and begin understanding what's going on. In the interest of time, I'm not going to go into details. These are the first 2 defensive projects we did. First, not harm. So we looked at whether we have disuse atrophy and increased fibrosis. So Nikos, one of the studies he did, he showed that we have no signs of regression. Because when you unload the heart, it's like putting your broken arm in the cast, right? It's going to get atrophic if it doesn't work. So people were thinking that maybe this atrophy will happen when the heart doesn't work. We looked at it by histopathology, electron microscopy, confocal microstructural T-tubule, metabolic data, and molecular data. We didn't find. This is partial unloading. This is not full unloading. The heart still beats and works, so it doesn't get atrophic. So we rule out this, because first you don't want a heart, right? Then the second thing, there were some reports, mixed reports, the reports from Houston, Brackman and Bad and Julia Amion-Torre that worked here, right? They were showing that maybe some of this interstitial fibrosis goes down. But other reports were showing increase, small numbers. So now we have a paper under review which shows that in 142 patients, that the fibrosis, the interstitial fibrosis, in the ones that they will respond, it will go down. I'm not talking about scar after an MI. I'm talking about the interstitial fibrosis. In the ones that they will respond, it will go down. As I said, the main reason we're doing it is to search for mechanisms of recovery. So I'm not going to go into the details, but when we screen the genes and the proteins and everything to see where the smell comes from, what is driving this response, we get all these changes in the pathways. And then we go like, okay, where are we going to put the money now? Where are we going to go after? Omar, again, put a study together where look at the time course. So maybe the time course can give you clues about the mechanism, right? And the time course, as you can see here, is quick. So we went first after metabolism because the changes in metabolism happen quickly. we got metabolomics. And then I'm going to summarize in the interest of time the results here. We knew that we will find this from other heart failure studies, that the glycolysis, the TCA cycle will be down and we're going to have less mitochondria. What we found was glycolysis going up, but not going into the TCA cycle, the Krebs cycle. We found a block there. So what was the implication of this? Well, we know from the skeletal muscle that when you have this mismatch and the increased glycolysis doesn't fit the TCA cycle, which in the responders seem to do it, we know from the skeletal muscle that when you train, condition, and maybe in this case reload and condition the heart, you can improve the mitochondria. So based on these bench findings, the bedside study we are doing now, and Joseph is running that, after the first phase that we unload the patients with an LVAD, we move on to do what? To reload them. So when the reduction of the LVDD on the echo plateaus and we shrink the heart to normal, we begin in a controlled way to turn down the pump slowly, not just for half an hour like we do the echoes, but slowly to test whether these will improve the cardiac metabolism and alleviate the mismatch and the block I showed you before. And this study is ongoing now. We have almost enrolled 4. So a grant that we have going on and a study we're doing now is, okay, we have the responder, non-responder, we have this block here. What happens to these increased glycolytic intermediates that they don't go into the mitochondria and the Krebs cycle? What happens to those? So we hypothesize that they go to other things that they might help. And indeed, and in the interest of time, I'm not going to go into the details, but what we found here at the metabolite level, I don't want to bore you with too much basic science, and what we found at the protein level is that these two pathways here, the pentose phosphate and the 1-carbon, were upregulated. So this glycolysis is not going into the TCA cycle, it's being shifted to these two pathways that they are known to be cardioprotective by doing 2 things, by reducing the oxidation and by using these molecules for repair. So the idea is that this protection and cardioprotection and repair, it leads to recovery through partly this shifting of the glycolytic intermediates. And now we're doing what? We're doing flux analysis with stable isotopes that we infuse in the patients 2 hours before the surgeons give us the tissue, so we can prove what we saw in the snapshots from the biopsies we're getting, whether it's going left and right, because metabolism is like a labyrinth, right? So we're doing this now. So what is the strategy to impact beyond the small LVAD population? We're using, again, the cancer field to guide us. Why? Well, the NIH, the Cancer Institute, has this exceptional responders initiative. So what do? Well, they take all these patients that we all heard about, that they cure their cancer, and they're putting money on them to understand not what went wrong, but what went right, to learn from them. They're putting a lot of money. So Chris is running the Innova Institute, right? He tweets. He better not tweet at that. We need something like this in heart failure, he says. I call Chris. Chris, we have a paper with you guys that we're doing with your junior faculty that you sent to me. We have this. This is what we are doing. This is our exceptional responders. Of course we need something like this in heart failure. We have it, and you guys are part of it. That's what we have, right? We're trying to learn from the success. How did we find the beta blockers? We are proud about many things in Utah, right? Artificial heart, long QT. One of the things we are proud is the revolution in beta blockers. How did we find the beta blockers? That they work in heart failure. How did we find the ACE inhibitors? We found a bad pathway and we blocked it, right? So this is a different paradigm. Instead of finding something bad and blocking it, we're finding something new and enhancing it. So Dagman and Berhoff wrote the same thing, that this could be a paradigm shift. We learn from the success to find pathways that are there to repair and enhance them. And just to make it specific, we're going to get the core, we're going to phenotype the patients, we're going to get these exceptional responders at the cancer field, and then we're going to go and get the heart transplant. And then we don't know, is this an association, is this a mechanism? Then we know to go back to the animal, to knock it down, overexpress it, and then if it pans out to be the mechanism and not just the creatinine gets better, the bilirubin gets better. Many things get better when you put these things in. Is this the mechanism or is it just an epiphenomenon? In order to do that, you need to do the animal study, right? And then you're going to bring it back. So you're going to do the full circle. Can you become more specific? Yes, I can. So how do we start from them and go to the full? We're going to start transcriptomic, proteomic, metabolomic. We're going to have responder, non-responder, as I showed you before. And then based on these differences, you will redirect your animal studies to knock out or overexpress these things that you're finding to see whether this is the mechanism, to bring it back as a new therapeutic target. Forget the LVAD patients, for the whole thing that is breaking the bank, heart failure epidemic. Let's become more specific. These are examples of things that we are finding between the responders and non-responders. And we have 3 knockout and overexpression models right now going after them to see whether by doing that, we will find this. And then Merck got interested, Pfizer, they are knocking the door because they would like to test these things, right? I'm wrapping up. This is an iceberg. I always like to show this because I was always getting questions about the first part of the talk and never about the second. And I was like, I need to show to people that we are not really doing this for the LVAD patients. The LVAD patients are the tip of the iceberg. Yeah, we will figure out the explantation criteria and the sustainability and help this small population. But the main reason we're doing what we're doing is the bottom of the iceberg, to use this tissue and the blood. And I'm glad that in this institution this is realized, and you guys are doing such a great work with your group here in retaining all of these precious tissues and blood in order to understand the therapeutic targets and impact the whole field. So we have recovery, right? We have the animal models, the responders and the non-responders. We're looking in metabolism. These are 2 of my closer collaborators. We are also looking at other things. So Omar, I showed you before, is leading this group with genomics and epigenomics. We are also doing non-coding RNA with Newcastle and MGH. Sarah is doing the phosphoproteomic work in our institution. With WashU, you may have seen our Nature Medicine paper about resident macrophages, and we're looking in innate immunity because we don't really know what is driving. It's not going to be a magic bullet. Heart failure is heterogeneous. We're trying to understand at every level how the heart recovers so it can impact. We're doing T-tubules, I showed you before. We're doing the regeneration work with Karolinska and UT Southwestern, vascular physiology with our group, and it boils down, and in the grant that Arvind mentioned with AHA, it boils down to what? It boils down to not what the doctors think, but the patient-reported outcomes. And Joseph and Ben are getting whatever we are finding to the patient-reported outcome, because what we think is not always the most important thing. And we have all seen the push now to include in all of the studies patient-reported outcomes to see what the patients think as well. History. We are in a historic place. So we usually start with history. I'm going to finish with history. You guys are proud here about all of the things we're done. We are also proud about our contributions. This is Kolf. The rumor is that he may be one of the few people more harsh than DeBakey, and that's I can confirm this rumor in Utah. But sometimes that's how you not to be in order to get things done, right? So after 20 years, I mean, DeBakey and Denton Cooley were also trying. Barney Clark became the first human being to get the first total artificial heart, and that was a real moment for the MCS field, which was trying from the 60s to materialize, right? And this is Jeff Anderson, one of my mentors, who was the cardiologist, convinced Barney Clark, the Seattle from dentist, to become the first human being to remove his heart for long term, not just short term. It was done here in Houston, but long term. Durable disease. This is my mentor celebrating here the team and the pipeline between the University of Athens and Utah. That's how I ended up in Utah as well. And Moulopoulos, the guy who became the dean, and he's the first author in the first balloon pump paper in docs with Kolf. And the other guys, some of them, you know how life is. Some of them will stay in the US, some will go back and create a pipeline. And this time, this is the research they were doing in the big house to do the artificial heart. That was a moonshot effect for the field of MCS, because it shows that these can be done now. And this is a lesson for our recovery field as well. Passion, there's a lot of passion in that room there. The passion within reason is required to advance the whole field, and that's what these people had. And we lived with them and grew up with them, and I can reassure you, as you know from Cooley and DeBakey in this city, that you need to be passionate about the field to push it forward. So back then, the passion and the vision was to replace biology with technology. That's why they were removing the heart and put the vision of the program now is to understand and manipulate biology using technology. And that's what I've showed you that we're trying to do. In summary, the VAD population, I hope I showed you enough evidence, could be used as a unique model to begin understanding recovery with this cancer analogy of exceptional responders. We're going to take this from the tip of the iceberg, go to the bottom, understand how heart failure works, and then we're going to apply this to the entire heart failure population. These are our patients. That's why we're doing all these things for our patients. This is our team. We do funny pictures every year, and we also do a serious one. So, our coordinators, and this is a recovery symposium that Arvind and people from your group came over the years, and I invite you to come in January. We do it before the MLK weekend so we can unleash people to play in the mountains after Friday. So that's why people come. All these people, they don't come for the conference. And this is the team all over the world doing the work. And I'd like to thank both the clinical and the research teams. I spend 50% of my time in the clinic and the other 50 administration and research. So with this, I'd like to open it. I thank you again for your attention and open it to questions.
Thank you. I think there's a lot to learn from recovery, but I think I'm also going to learn how to torture fellows more that you've shown. You torture better than we do.
And they send their brothers. James is the brother of Omar. So you torture the first and the second counts.
All right. This is an excellent presentation, Dr. Drakos. Can you guys hear me? Okay. All right. Just a couple of questions. The one was that when you talk of myocardial recovery and LVAD explantation criteria, amongst them, because non-ischemic cardiomyopathies are more likely to respond than someone who has, say, 30 to 40% myocardial scar on MRI. It tends to be a biventricular process. And when you're looking at LVAD explantation criteria, you're looking at LV and diastolic dimension, you're looking at LVEF. I didn't see any RV function parameters.
That's a great question.
As a matter of fact, I think even on your one that you showed, the imaging was a limited view, apical four-chamber, but the RV function actually hadn't recovered, probably was looking a little worse. So that's question number one, that are you looking at RV criteria? And then the second one is just more of a programmatic thing, that how do you do a full explantation of your device?
That's a great question also. Yeah, thank you. No, these are great questions, both of them. RV. Okay. Well, RV is one of the 5 shames of modern cardiovascular disease, right? Cardiorenal, shock, arrest, RV. I mean, I have a butcher saying, you guys, all these years, when I cut the brain, it's complex. When I cut the heart, just 4 holes. And you guys doing all these years, all this research, and you haven't figured it out yet? And imagine that we have not even figured out anything about the RV, not just in this population, right? We know almost nothing, and the NIH is pushing on all this. So you're asking, are you LV-centric when you're doing all this work? If the RV fails, you're done, right? The answer to this is that we look at the RV as well. And the echo parameters I showed you talk mostly about the LV. But when you go to the right heart cath, and we also have the optional criteria of the cardiopulmonary exercise test, you cannot have a normal cardiac output if the RV is not working well, because it's not going to support it, unless it works like a conduit, which we try to understand why sometimes the RV works like a conduit, even in congenital disease, and sometimes does not. So until we reach there, what do? We look at the RV, of course, on the echo, and we're never going to explant somebody who the RV looks horrible, but we don't have specific ejection fraction and dimensions criteria for the RV yet. However, we are very careful when we look at the hemodynamics that they will include how the RV works, especially the cardiac output and the cardiopulmonary exercise test. So that's a great question, and that's one of the areas that we are moving now, and we have studies underway to look at this. When you go to the JACC papers I showed, you will see all of the detailed data there about the RV, RV-EDD, with the limitations you have from the echo. And MRI would be the way to do it, so you can see the RV better, right? Because it just sits like that. But doing an MRI in LVAD patients, is impossible. And also before, to do it to quantify the fibrosis is also difficult because of the artifact of the pacemaker. The second question you ask is about the way to remove the pump. So the surgeons are doing all sorts of things, and the interventional cardiologists now are beginning decommissioning and putting a graft. So all of these has not really been studied which of the two is better. The patients like more the decommissioning. We always take everything out. The reason we take everything out in Houston, Bud Frazier, all of the explantations he did, I don't know what you guys are doing here, but he left the pumps in and he published this in JHLT. So both approaches are acceptable. We take out everything. We don't leave the hardware in. Barry.
Yeah, Stavros, phenomenal talk, and first, congratulations on the scientific rigor you bring to this field and your very impressive body of work. My question to you is on regeneration, and really the recent trial looked at mesenchymal stem cells and LVADs to see if that would help recovery, and that was a negative trial. And so I wanted to see, one, do you believe in a role for, a potential role for it? And if so, what's the next step to regenerate the regeneration?
That's great. So when I showed the team, right, I showed this thing here at the end. We're doing regeneration studies here. So we have not really shown, and I was complaining when NIH spent the money for that trial. I was like, we're doing all this work and others are doing this work to find what to do. That was pushed by the stem cell people, right? That they wanted to test it. But you didn't have any indication that that was the mechanism that was driving. If we find that in these studies we're doing now, we're doing the carbon-14, we're using, you may have seen this science paper that you use the atomic bomb explosion and the rate that the heart gets out the isotope to know whether the regeneration is going up. We are sending 100 grams of heart tissue to Karolinska to do this same protocol. If we figure out that, then we might be able to use regeneration. And then maybe regeneration is one of the mechanisms. But that trial was done prematurely just because it made sense. And you know how powerful is the regenerative medicine field, right? I'm not going to go more than that.
Excellent presentation, Dr. Drakos. It was great. What is your experience and take on pulsatility, pulsatile versus continuous flow VADs? Because there is some suggestion that pulsatile flow VADs did better on loading of the LV.
Yeah, no, we know that. And the Germans actually published their experience. They have the largest experience. And they showed that since we abandoned the pulsatile pumps, they have better results, worse results with the continuous flow. You know, that's very dear to my heart because my PhD was pulsatile versus no pulsatile flow in large animals, in shock and heart failure. So there's a reason. Well, let me go back because we're in Houston. So when heart surgery started, the bypass machines were easy to be non-continuous, right? It's easier to have rotary. That's what they use in bypass for a few hours. So Veslovsky, who was leading the field, wrote in New England Journal of Medicine something that remained in the history. It's the audacity sometimes of the doctors, us. The pulsatile flow of the heart is a limitation of the heart design as an organ. So he blamed even the God and the evolution for. There's a reason we are pulsatile, right? There's a reason. There must be a reason we are not continuous flow and there's a pulse there. So, and that's probably why, and we're trying to figure this. Bill Cornwell is doing great work at the University of Colorado. We are collaborating with Bill to understand better. But the decreased pulsatility, these non-pulsatile pumps end up with decreased pulsatility. It's not totally non-pulsatile because the heart still works. It's probably not helping as much. And that's why when we have pulsatile pumps, we abandon them for engineering reasons because they need to have valves and all these things and they tend to fail. And the non-pulsatile pumps, it's just a pump, you know. So it's easier by engineering-wise. But the engineers now and the scientists and everybody, industry and academia working together, understand that we need to go back to pulsatile pumps. And I agree with you. We have also shown vascular studies. We just published actually, again, that pulse makes a difference for the periphery. We didn't confirm this in the heart. For the coronaries, it was good enough. The decreased pulsatility, we just published a study in heart failure with ex vivo studies we did in coronaries. We isolated from this. But on the periphery likes the pulsatility. And the periphery is gonna spill out all these molecules that they will, you know, help you. So it makes sense to have pulse. And we gather more and more data about this now. Great question.
Yeah, excellent talk. At least we have seen that axial flow devices seem to not only decrease the wedge pressure better, but also shrink the LV a little bit better than centrifugal pumps. And do you anticipate? I mean, do you see a difference?
I hear you, loud and clear. When we did this study, we did the same thing. We compared HeartMate 2 and HeartWares. So Mohammed, in this overall, but we may have been underpowered to show that. Showed that the axial flow pumps and the centrifugals, hardware, were probably similar. However, when we look at Intermax and when we look at other data we are collecting now, we agree with you that it seems that the axial flow pumps are a little bit better in inducing this. For reasons we don't understand very well, probably has to do with how they work. Whether you can do the same with the other pumps, if you have a sensor telling you what's unloading and by improving their function by changing the dose of the LVAD. We have the dose in medications. The LVAD also has a dose, right? the RPM. We're doing this blindly. We do the echo every 3 months. If you had a sensor on a daily basis, if you had the cardiomems in the in the RA and the LA to tell you what's going on, and maybe you would get similar results. I don't know. I'm just hypothesizing.
No, I mean, at least observation has been, even though the wedge is actually, if you were to measure unloading based on wedge pressure, yes, there is, decrease in maybe equivalent wedge
It was
pressure.
independent of the hemodynamic findings, what you saw. That's what you're saying.
No, what I'm saying is, if you look at two patients with equivalent, let's say, equivalent decrease in wedge pressure, the LV dimension seems to be
I hear
smaller.
you. So it was independent. So despite the fact that they unloaded the heart similarly, you saw something. Well, this is, again, these are the things we need to understand better. Counterpulsation also is another way that is very attractive. So if you see that, and you see that the heart shrinks better despite similar hemodynamics, then you need to understand it better. So having the tissue, and you guys have that. So we would love to see a study from here coming out, saying what you said, and attaching to it fibrosis, hypertrophy. So you begin understanding what happened in these hearts shrink more with this different type of pump. These are the studies that the industry is waiting us to do, right, in order to shift their focus on what type of pumps to produce down the road.
I think the mechanics, and I don't know what your thoughts are, is if you think about the centrifugal pumps at the apex versus the axial flow pump, which is not sitting in the pericardium at the apex, one, does it impact the torsion as much? And then two, if you the Everhart pump, I don't know if you guys are doing them, they've changed the design where the cannula does not come all the way into the LV. So
Are you doing the Everhart here?
Not yet. I think we've not started it. We're working on that.
No, I'm familiar with the pump. We've been talking to them. I agree that the mechanics, I showed the data about the rotational mechanics. We were talking about it at dinner last night. It's very important. And, these hearts, if you look at them under the microscope, they are bent out, they are end stage. And if you also think that we go there, we remove the apex, which is one of the crucial parts to do the rotational mechanics, and we still recover a few. The plasticity of it's amazing. If you think about it, it's amazing. We have a burned out heart, patient is end stage, we go in, we remove the core, which is a crucial part of the function of the heart, and we still recover a few. So this shows to you the potential of this field if you go earlier. In a few years, we're going to have pumps that they will go in the cath lab, right? For a few, the company is doing them. Albumin is doing one now. So you will just go there, we're not going to remove the core, and you're going to leave the heart intact, and then unload the heart. Maybe you do it at the same time you do CRT. Maybe it's one box, given that the companies that they have the VATs now, they are the ones that they have the CRT. Maybe they can produce the same thing, right? And then you turn off the one and then continue. So this is where we are going. And understanding better these things will position us and the centers that are winning and the industry who is going to invest into this to use this coming era of lower, minimally invasive pumps to go to earlier patients. That I showed you all this data, bench to bedside, suggesting that the less burnout, the less advanced, the more the recoverability. But if you go to less advanced patients, they're not going to let you touch them and crack their chest and put pumps in. However, if you had a CRT kind of pump that goes in the cath lab, right, they might have let you do it even if they're class 3. If you promise to them that I'm going to restage you from class 3 to class 1, they might let you do it if you're not going to crack their chest, right? So this is where the field is going, where the recoverability will be higher in this population, we think.
Absolutely. Well, thank you all. I think we're 10 minutes over. I want to remind you at 9:45, you can go to the live casting and ask more questions if you want. Thank you.
Thank you, guys. Thank you.